Hello and welcome everybody for another MEDtalkx radio show. We're broadcasting live on Pendle Community Radio, WAS 103.1 FM, as well as our YouTube and Facebook channels. So please do search for MEDtalkx. You can certainly interact with us, ask questions, fire away, because today we've got a really fascinating discussion, something I'm really looking forward to discuss further. So couple of numbers for you to be aware of. There is a WhatsApp number, so it's 07522 723 455. There's also a studio number, 01282 723 455. So I'll let Fahim, my co-host, do the introductions.
Thank you so much, Mehran, and a warm welcome and good evening to everyone watching wherever you may be. I'm really pleased and honored and delighted to welcome our guest tonight. We have Dr. Magdy Aglan, who is a pain consultant in the northwest of England and has been for 23 years. He's a graduate of Alexandria University in Egypt and did his postgraduate training here in the UK. And he also, as you can probably see behind him, is the medical director of Pain Consultants Limited. So really a fountain of knowledge, all to do with pain management this evening. In addition to Dr. Aglan, I'm pleased to say we also have Miss Sannah Khan as well, who's a surgical pharmacist in the private sector. She's the pain management lead as well for pre-op or pre-operative pain at the hospital where she works, and also hosts a podcast as well, which is really useful, I gather, for people sitting there examinations to do with pharmacy training. So obviously very industrious, like Dr. Aglan as well. A warm welcome to you both.
Thank you.
May I first start with you, Dr. Aglan? So obviously for the audience, please, can you give us a bit of a background to actually what is pain and this perception of pain that people perceive it to be?
Yeah, pain is, I've been identified like unpleasant sensory and emotional experience due to actual tissue damage, potential tissue damage, or even described in that damage. So by this way, we covered all the possibility, either there is a nociceptive pain or neuropathic pain or even psychogenic pain. There is no damage at all, but the patient still feel pain, so they report it. So but in a simpler way, for us, pain is whatever the patient say it hurts. And that's good things and bad things. The good things about it that the patient really tell you where do you feel the pain and how important it is and the effect of it. But the bad things, it's not the bad exactly, but the downside of it, that it's subjective. So it's only the patient who can measure that, and it's only him who can measure the effect of it on his quality of life. That's why it's very important. So we tend to ask the patient to measure the pain so we can compare between different types. That's a definition of pain. But really, we have to believe the patient, and we have to react to it because it's his word. And we cannot deny it. That's a pain perception. We all theoretically feel the pain when we feel like a heat temperature at skin about 40 degrees. But we all differ in what we call pain tolerance. So perception, all human, unless you are a computer, your pain threshold will be different. But we all feel it at that level. But after that, we all vary in the limit of how much we can tolerate the pain before we react. So that's totally individual, depending on loads of many factors. So that's basically the definition of pain, but people tend to classify it where you feel it anatomically, or actually two types, like acute pain, or like example, the commonest, which post-operative pain. And I'm sure Sannah is an expert in that field, and the chronic pain, that's my department.
Okay. And Dr. Aglan, just taking that a bit forward as well, we've already had a question come in tonight. What is pain? Is it nerve or tissue damage? Is it physical or emotionally related, is what we're being asked. Can you tell us a little bit about what causes pain and what else can you say about it?
Yeah. Definitely, from the definition, it's unpleasant, and it is a mixture of both the physical and the psychological. So, for example, if you got like a pressure or cut or wound, whatever, or back pain or a disc or any cause to cause pain, there is a potential tissue damage. Something has gone wrong, and that tends to stimulate the special receptors in our body which transmit pain, and there is a special pathway to transmit that stimulation through the peripheral nerve, through the spinal cord, to the brain where we feel the pain. Exactly, we locate where the pain coming from and how bad it is. That's the brain does that. So and if you get pain for a long time, it's bound to affect your psychology, make you frustrated, make you depressed. So pain itself is recognized as a disease. It's got a lot of effects, not only on the physical function of the patient, but also on the psychological aspect of it as well.
Okay.
Great, thank you, Dr. Aglan. I guess, Sannah, if we move on to yourself, Dr. Aglan referred to special receptors. We don't need to go into the detail of that, but I guess as a pharmacist, what's your interaction been with the public? And also people may have heard about the pain ladder. Could you tell us a little bit more about that?
Yeah, of course. Thank you. So I work in the private healthcare sector at the moment, but obviously I've worked in the community as well. So the pain ladder is something that the World Health Organization has developed, and it basically starts at, I don't want to say the bottom, but it starts at the best and most easily tolerated medicines like paracetamol, the sort of less potent and less sort of risky NSAIDs like ibuprofen, and then it moves sort of up in potency and actually in more of a unpleasant side effect profile sometimes as well. And you sort of start at the lowest type of medicine or related to what sort of pain you're feeling, and then we move up. It's like a step up treatment plan. So you start at paracetamol, and then say you give the patient sort of a nice time limit, so you know that they're not always going to work straight away. You see patients say they've got a headache or an earache, a toothache. You ask what type of pain it is, and like Dr. Aglan said, it's not all about quantitative sort of scales and how it feels like that. You end up being like a poet, so you have to explain to the patients, you can tell me how it feels. Does it feel sharp or dull? Is it spreading? Is it sensitive? Lying, sitting? What makes it worse? And it's very much like a story. So then you usually start off, you don't always start off at the lowest sort of the ladder, if that makes sense. You won't always give someone who's got like a piercing toothache like one paracetamol 2 times a day or something. So you sort of have to really understand the patient's experience and really connect to them, not just in sort of a guidance way, not just looking at the pain ladder, but quite emotionally as well. It's a really personal connection with each patient. So I think that's what we use the pain ladder for, both in community and in I work a lot with peri-operative care. So we sort of start at the top of the ladder. When patients have their hips and knees replaced, you don't really start off with paracetamol. You start off with stuff like oxycodone and morphine, and then you move down as the pain gets more bearable. And even knowing when to step down for different patients is different. It's incredibly different. Like age makes a difference. How many hips they've had replaced makes a difference. There's loads of factors to take into account. So I think it's fascinating. The pain ladder is a brilliant thing.
Yeah, no, and it's interesting you talked about scales, and sometimes people have difficulty explaining or quantifying, isn't it? So scales make it potentially easier, but as both of you have said, it's trying to get that subjective experience of that pain.
If I add a bit like simple explanation, like the idea of the ladder to guide just here and internationally, because lots of countries will not even using pain, but it's step by step, as Sannah said kindly, and we tend to ask the patient to measure their own pain. There's too many ways, but we ask them just to give it a number out of 10. At 1 end 0, no pain at all, and the other end 10 at the maximum imaginable pain. So 5 in the middle, moderate pain, 7 or more severe pain, 3 or 4 mild. So depending on the patient measuring the score, we know if it's mild, we start by mild analgesia. If it's moderate, start by moderate analgesia. And if it's severe, as Sannah kindly says, especially post-operative, we start with very strong analgesia. You don't do it one by one. It's just a guidance for people to select, depending on the patient, exactly their own measurement. And the measurement also is very important, because when you give an intervention or a medication or whatever it is, you measure the effect of it. So you see how much that reduces the patient's pain. Definitely in acute pain, we look for very good response. I think nearer to 0 or 1. But in chronic pain, we aim for about 50% improvement. If you get chronic pain and you get 50%, most of the patients can cope with that very well.
Yeah, absolutely. And Sannah, where does the over-the-counter supply of pain relief come in? At what point do they actually need more specialist advice?
So in community pharmacy, a lot of newly qualified pharmacists and local community pharmacists will know that we have what we call red flags. So there's actually a lot more available over the counter than we realize for a lot more, not severe, but what feel like worrying conditions. So we've got the standard paracetamol tablets, ibuprofen, if you're able to use them. We've also got aspirin, but we're tending to sort of move away from the aspirin just because of the bleeding risks and the gastro sort of upsets, because it can upset your stomach. It does increase your bleeding risk quite a bit. And there's stuff out there that's better recommended, like if you've got like a toothache or a sore throat, instead of having something that will give you that has a chance of giving you some systemic side effects, like a stomach pain or diarrhea or something, you can have something that's quite localized. Like we've got benzocaine, and Diflam, the mouthwashes and the throat sprays, which are fantastic. Where you would sort of where I would refer to someone like Dr. Aglan would be if it was accompanied by something quite worrying, like people sometimes have pain in one area and then it feels like more of an issue if they've got numbness in another area, or if it's just not being touched by the over-the-counter medicines. And even within that, even though the World Health Organization pain ladder doesn't include the over-the-counter medicines, we still have guidance amongst the sort of the national institutions. So we understand that you start usually at localized pain relief, then you move on to stuff that you can take orally, and then if it's not working, if it's persistent or worsening, then I might just send them to Dr. Aglan.
Dr. Aglan, yeah, what is it exactly that a pain consultant does? I think with the listeners and viewers could actually do with you elucidating what it is you do your day-to-day. Can you give us an idea what you do day-to-day?
That's a very good question, and I'm glad that you asked that. Pain, like any, as I said, it's a chronic disease. So like when you deal with any disease, so we see the patients, we assess them, and that means we take history. We may need to do investigations, either radiologically or bloods or other special tests for certain condition. Then we come to diagnosis. And once you diagnose, now we make a plan for treatment. The plan may include generally giving some pain killers, certain drugs for certain types of pain, and include advice again on practice. We do have physiotherapist with us. We have a psychologist for us. So the patient has a bit of psychology. Again, we have to help him to cope. Plus, what I do specifically is called interventional pain medicine, which I'm a consultant in. So we do intervene. What that means, basically, it's an injections. So there is too many injections for different parts of the body. The idea is to intervene at the source of the pain or at the nerves which transmit that pain to the brain. So in many areas, we do different types of injection, but the idea of the injection either to help diagnosis or to treat. In some cases, it's both. But when you do diagnostic block, for example, like a special nerve root block for a disc or whatever, and the patient not fit for surgery or doesn't want surgery, we can kill that nerve with a special electricity. And that goes with a lot of other things. Again, if you, for example, block at the base of the skull a nerve called occipital, and that's very commonly involved in a lot of headache. Then if you block that with local anesthetic and the patient get more than 50% headache improvement, we can kill that nerve with heat. So, and not only treat, we do also follow-up care. So the idea basically is to help the patient. Chronic pain is, we always follow what we call the bio-psycho-social model. There must be something wrong in the body to start that pain, and then that pain has been long enough, usually more than 3 months, to become chronic every day. So that affects your daily activity, affect your sleep, affect your relationship, and may make you frustrated, depressed. That's the psychological aspect, and it will affect your social activity as well. It may affect your relationship, and more importantly, may not be able to help you to do your job back again. Then you lose the work and you lose money, which is a serious effect. So once we assess all that biopsychosocial model, again, we treat the patient in every aspect. So in a clinic like what we have a multidisciplinary team. I'm the lead as a consultant, but there is physio, psychologist, occupational health, psychiatrist if needed. All these people is available to guide the patient, take them from severe pain to bearable pain, and psychologically again from unable to cope to be able to cope. We may not be able to cure him, that's mean we finish the chronic pain, especially if there's already some damage which we can't correct. But if we catch the patient early in certain condition, we do achieve full relief. But if the condition has been there for some time is a bit difficult to clear the cause totally. So we aim for what we call pain management or pain control, which basically, in one word, improving the quality of the life of the patients.
Excellent. And Sannah, obviously, Dr. Aglan's explained what his role is. Can you tell us a little bit about what acute pain actually means? I know there are actually definitions as to what it is and how that actually relates to your role as a pharmacist.
Yes, thank you for him. So, unlike Dr. Aglan, I don't have to work so hard to get full pain relief for my patients. So, acute pain is defined largely as pain that's been there for less than 3 months, and it's usually of more of a physical nature. It's more to do with some sort of tissue damage, trauma. It can be from a burn. It can be from a fracture. It can be like it can be caused by things like arthritis. A lot of the patients that I see, they've got osteoarthritis of the hip or the knee. That's why they need it replaced. But they've got some sort of acute pain. They've had a procedure to rectify that, and then they've got some more acute pain from their procedures. And I'm also quite blessed in that we've got lots of different treatments for pain in the community and for chronic pain. Like Dr. Aglan said, there's so many things out there and there's so many people involved in the pain sort of management for chronic pain. We have the same thing in hospitals for acute pain. So we'll have physiotherapists, but for a while they do, when they make the patients walk around a bit, in contrast to Dr. Aglan's sort of expertise, we see that after the patients have been up and about, people tend to be in a bit more pain than they were before they got out of bed. But it's just that sort of idea that it has to get a little bit worse before it gets a bit better. But acute pain is usually managed, and the treatments are usually readily accepted. So instead of them sort of, people tend to stay away from the more potent analgesics, especially things like opioids, like oxycodone and morphine, because they have such a stigma attached to them. But when you're in that much pain, it's important to speak to the patients, and that's my role as an acute surgical post-op pharmacist. I speak to the patients prior to their procedures. I warn them that it is going to hurt because they are basically having like their bones broken. It's basically the equivalent of being stabbed and burned and then stitched back together, so it's going to hurt. And then I think that sort of psychological preparedness, there's a difference. I think the consultants that I see, the anaesthetists and the orthopedic consultants that I work with, some of them do give quite stark, clear warnings with sort of not sugar-coated at all, so the patients know exactly what they're going in for. Those patients tend to recover better, and they usually have lower pain scores, which is fascinating. And then I always aim for a pain score of 0, unlike that Dr. Aglan. It must be really frustrating to see where you can't get it down to 0, I guess. So I think I'm quite blessed in that sense, that we're always trying to get the patients down to a level where they don't feel any pain and they can get a good night's sleeps and they can start eating, because I think something to do with pain, it just stops your appetite. People just stop eating, they stop wanting to get out of bed, even if it's so distressful, like it's so distressing. People who have had almost no pain before their surgery or had a little bit of arthritic pain, then they've had a procedure and they're just in ridiculous pain that they've never felt before. So I think connecting with the patient is probably the most important thing in my job.
If I add one more point, exactly, is very important, which is one of the serious effects of pain is lack of sleep.
Yeah.
And that's important both in the chronic and acute pain. And when I was doing acute pain like 30 years ago at the beginning of my career, it was sometimes not analgesia the patients. We just once we improve his sleep by just pain, just sleeping medicine, he quickly recovers. So some people forget sleep, but sleep is very essential to improve and help, so you can get a proper pain control.
Yeah, and just to also add, it's great to have so many viewers on our social media platforms. So please, if you do like what you've heard, do give a thumbs up and subscribe to our channel. And there's questions starting to flow through, but we've also got lots of questions to ask Dr. Aglan and Sannah. Sannah, if we continue with that, what are the kind of new developments in post-operative pain management that you can share with the public?
I might be a bit sneaky and go from new to sort of, well, recently, I think the best thing for me has been seeing patients who have got a unicondylar, so it's a different kind of knee replacement, go from a 3-day, 3-night stay in hospital to literally being a day case. So they come in the morning and then they go home in the evening. That's amazing for hospitals if they start using the same sort of treatments in the NHS. What we've seen is a couple of doses of the drug that's been in the news, actually, dexamethasone. They keep calling the wonder drug. It's not the cure to COVID, but it's brilliant at reducing inflammation. I thought I'd just point that out. But it's brilliant at reducing inflammation. It's been found in lots of trials, lots of tried and tested experiences from consultants around the UK, and I'm sure around the world, that it improves recovery. It has improved reduced recovery time, improved recovery rates, improved pain tolerance, everything. Because obviously, if you see a patient who has had no steroid or no and the anti-inflammatories like ibuprofen and stuff, the difference between the leg of a person who has and hasn't is huge. Like, it's just the swelling, the inflammation is so painful. So it's just literally 2 doses of that dexamethasone post-op. It's literally halved the stay in hospital, which has been amazing. I don't think it's used everywhere at the moment, because I've been involved in some trials with some hospitals, some anaesthetists and stuff, but that's been one of the newer developments in orthopedic surgery. But in terms of like novel, different approaches to acute pain, we've got the TENS machine, we've got heat, we've got ice, stuff like that. So if I twist the question a bit and make it about like different alternative modes to pain relief, then in the community we do recommend TENS machines, especially for stuff like menstrual cramps and stuff, because they, like Dr. Aglan said, mood is a manifestation of a difference in chemical imbalance. So they say that the TENS machine, it releases endorphins, and that causes the pain reduce, or the perception of pain to be reduced. We found in hospital, a lot of elderly patients can't take the ibuprofen and the naproxen and things like that because of their kidney issues. So instead, if we give them ice for about 15 minutes off, the effect is almost exactly the same, and they don't feel as much pain, which is actually beautiful to see, because they haven't taken anything. They haven't been subjected to a load of side effects, which they didn't need anyway. Their kidneys are saved, and so are their stomachs. They're not feeling sick, so they can eat, and it's just a nice pack which they can use at home as well.
Dr. Aglan, you're about to say something there.
Yeah, it just came to me about the weak dose of steroids. It's been also proven to help COVID, which really important for all of us at the moment. And I'm sure, at least in our hospital, it may have helped to reduce some of the mortality. So although we're going through the second wave, but touch wood, I hope it doesn't have the same high mortality at the first wave. And I think we are clinically more equipped, and hope for the best.
Yeah, and I guess just following from what Sannah mentioned, perhaps about 10 minutes ago, around the pain ladder. So obviously the post-operative management, you usually start high and then you try to wean yourself down. But what's the challenge in terms of anticholinergic burden and managing that in the community to make sure that there is someone reviewing the ongoing management of pain?
To be honest, I have to say that's one of the possibly areas which is not properly covered at the moment. Once the patient discharged from the hospital, The hospital team have got a bit of limited, unless we follow them up in the pain clinic. We got some nursing team doing phone calls to check, but that's on the pain generally, not only the medication. I'm not quite sure what the acute team does for that or not, but I think 2 years ago I was involved in a review that the use of, for example, one of the strong opioid has increased a lot in the community, and people was afraid at the time of the addiction plus the cost as well. So when we reviewed that, it was just possibly related, like post-operative instruction has changed from just discharge the patient after a hip or knee with morphine to a different, stronger drug. And there was a gap, as you rightly said, that, you know, we depended on the patient to be reviewed by the, you know, by the community team. But in some cases, that was not properly followed up, and the patients kept taking the drug for a long time. And that when there was a problem, and that actually, I guess at the moment it's been rectified, because we did in our area really guidance for the use of opioid in non-cancer patient, and that gone to all the GPs, so they're all aware of it now. And I think that problem is not as important as it was before. I hope that answers your question.
Yes, no, it did. Thank you.
Sannah, in terms of obviously placebos, we've had a question come in. Are placebos or psychological treatment an effective way of dealing with pain? Do you have any experience on this sort of question?
That's a very actually good point, to be honest. Placebo means that you give the patient some medicine and it has an effect. So if you give the patient any intervention and have no effect, it's called nocebo, which people don't use that term, but black it is. So in chronic pain generally, any intervention, if you give the patient help, we welcome that, but it depends what's the potential side effect of it. So generally when we look, especially with research publication, we accept placebo, that you give a patient inert material or pill of sugar or whatever, and the patient get about 30% or less improvement. We call that really not that strong. So when we look for a proper drug to have an effect, we aim for at least 50% improvement of the patient's pain, at least for the measured pain. So that's it. So placebo for us in chronic pain is actually welcomed. So the patient take, I used anything. Some patient came to me with like a watch and some brass in their hands and said, it does help me. I said, if it really does, I said, yes, sir, carry on. But in fact, when we started that like 10 years ago, we had some watches with some magnetic, and I did the research with it, and I took the magnet out of the watch. And actually 9 out of 10 patients felt better with just a piece of rubber on their hands. So for me, that's placebo response. It's useful, but it did not harm the patient. So I encourage it. Even if you talk to the patient nicely, the way you understand, the way you sympathize with the patient's body language, all that is a placebo response. And we use that, again, to reinforce that we are here to help. So placebo is not no effect. No, it's a weak effect, but from like, to the best of our knowledge, not active ingredient known to have an effect. But theoretically, it's been shown really that there's some chemicals, as Sannah may have said recently, endorphins, which is that endogenous morphine-like substances work in our body. So the patient, if you win like the lottery now, if you have serious pain, you will feel better. You know, nothing has happened, just we use that. And I think the point for that although our body really very specifically developed to feel and sense and transmit pain to the brain, but more importantly, there is also very good modulation. The body is designed to heal itself and try to reduce the pain experience by itself. So there is the main theory except for that's called gate theory. There's some cells, specific important cells in the spinal cord. So the transmission has to go through them before they go to the brain. So there is lots of interventions can open the gate so you feel more pain. So when you really don't show any respect for the patient or whatever that makes him feel pain, set away. Or if you really try to help him, understand him, give medication, and that Even rubbing the pain in the old, stages, when you have fallen your knee and you rub it, you feel better. And that's technically true, because with that rubbing, you stimulate receptors called A beta fibers, and that tend to close the gate, which transmit pain. So that's theoretically proven to make the patient feel less pain. So back again, the placebo for us, yes, it is there, and we welcome that, whatever we do, because at the end of the day, you would like to help the patient to cope better of whatever intervention you do. That's the idea.
So now I'll move on to a different question. I think that was really comprehensive. In terms of the US opioid addiction and to painkillers and so on, I think that's a big area of discussion and topic, and we want to prevent that happening to in Britain as well. But whenever you do prescribe an opioid, say for instance, post-operatively or just for acute pain, and someone's on it for say over a month, they're going to build some tolerance. So how do you manage these sort of patients and prevent them getting addicted to it? Do you get addicted to opioids?
Absolutely is the short answer, but the more interesting one is, if you ever buy a pack of cocodamol or anything containing codeine or dihydrocodeine in the community, you'll probably notice that it's the legal requirement. Every single box of codeine or dihydrocodeine has on it, can cause addiction, do not take for more than 3 days, because that is how long it takes. The body it's amazing, but I think sometimes to its own detriment. It can tolerate opioids and the effects quite quickly. And we tend to tell people, if the pain is lasting longer than the 3 days, Dr. Aglan. But in the world of peri-operative pain management, especially with people who have spinal surgeries, I've noticed they come in to have their surgeries, like spinal decompressions and things. It's very much like third, fourth, fifth line after trying a load of different pain relief that they have never stopped until they've come to see us and get their decompression sorted out. So they're on stuff like gabapentin, they're on things like pregabalin, they're on things like tramadol, all these very stigmatized drugs for the right reasons, because the body does tolerate them quite quickly, especially things like tramadol and cocodamol, things like that. So the thing that I was trying to focus on, I've not been in this role for very long, about 1.5 years. But the thing that I'm really interested in is after surgery. We've had a lot of people ring up post-discharge, and they call us and they say, I've not got the back pain anymore. These patients are amazing. When I'm used to hip and knee replacements, they can't get out of bed for 2 days. When they've had spinal decompressions, they are up and about and walking up and down stairs like a few hours later. It's brilliant, but it just means that they don't technically need those very physical pain relief medicines like codeine. They might stop it straight away, but they do feel a bit of withdrawal. Their stomachs do start messing up straight away. They do get a bit shivery and things. So what I think is needed in more the private sector and the NHS, and I'm sure Dr. Aglan's seen it in his clinic as well, I think trying to get people off the pain relief after surgery, stuff like hip and knee replacements, you won't need stuff like that for too long. You probably won't need your dihydrocodeine longer than a week. You'll be okay. Probably won't need your codeine longer than a week. We also tend to stay away from things like oxycodone for longer than 3 doses. So that's literally the morning, the night, and the morning after. That's when the pain is worst post-op. And then you can step down to the more tolerated pain relief that you can gauge whether the people in hospital can tolerate it, that they're not getting stomach upsets, things like that. So going back to your question, yes, you can definitely get tolerance and addiction dependence on these kinds of drugs. It's very real, and it's actually very scary because young patients are getting a lot more surgeries now, and it's not just stuff like an 80-year-old patient who has had like tramadol for about 10 years. It's people who've never had codeine in their whole lives, and the way it fixes pain is fantastic. It's absolutely fascinating because you can go from a 4 to a 0 if you have 60 milligrams of codeine in about half an hour. So that's brilliant, but we also need to make patients aware. I think that's our duty as pharmacists especially, that just be aware of what you're taking, just be aware of your pain. So sometimes maybe the pain can be a little bit of a positive experience, because if you experience it for a little bit, you just let that painkiller wear off, you know what's happening, you know that this pain is not as worse as the pain I was feeling before, maybe you can half the dose, maybe you can start stepping down. So as a pharmacist, post-discharge, I support patients a lot with taking them off the pain relief that we put them on. So it's not just getting rid of the pain, but it's getting rid of the pain, and then after the pain's gone, helping them manage getting rid of this tablet, because I don't think it's addressed very often, but being dependent on a painkiller is actually, it's a lot of work, because you always have to make sure it's there. You always have to make sure that you can function, because that's what addiction is. But yeah, that's what addiction is. It's not being able to function without it. So trying to make patients' quality of life better, not just their physiological sort of state of being, but everything. And I think, yeah, Fahim, definitely you can get addicted, but we're trying really hard to get them out of the disease state of pain, but then out of the disease state of addiction as well, if that makes sense.
Yeah, no, it does. Thank you, Sannah. Just following on from Fahim's question, so we've talked a little bit about nociceptive pain in the sense that it's about somatic sensation or a visceral type of pain. The other type is the neuropathic pain. So there's a different set of medications that we can try to help manage that. But I guess for viewers and listeners, when people communicate in letters talking about neuropathic pain, what is it and how can that be best managed?
Is that for me?
I think so.
Oh no, it was for Sannah, but
So I think Dr. Aglan is the
okay.
pain expert, if that's all right.
Yes, I will take that. I will take the point. Actually, the classification of pain as a nociceptive, which pain coming from tissue damage, or neuropathic, which basically coming from either nerve damage or properly nerve dysfunction, is a simple one. But it just help us to select certain drugs which can help in that condition and the other condition. So when we get the neuropathic pain, which basically pain due to dysfunction of a specific nerve, or a group of nerves, or a plexus of nerves, either somatic or autonomic or visceral, the patient usually complain of certain symptoms to help us to diagnose. Some other tests could be done to do that. But at the end of the day, yes, there is drugs known to work better on the nerve pain, as we call it, neuropathic pain, and we put them in like a class of groups. Some of them like amitriptyline, part of tricyclic antidepressant, then anticonvulsive drugs like either gabapentin or pregabalin, and also duloxetine for painful diabetic neuropathy, and then after that the opioid, and then after that there is also some topical application for neuropathic pain, which mainly topical anesthetic. The commonest one used in the hospital is something called Versatis, which basically is a lignocaine 5% plus, but strong enough to work through the skin. So it actually go through the skin and have a local effect on that painful area. And you put that plaster 12 hour on, take it 12 hour off. So there is, again, we follow algorithm one by one, depending on the effectiveness. We've done that long time ago, about algorithms for neuropathic pain, depending on the needed number to treat, how many patients you need to treat to get an effect, or needed number to harm, how many patients you treat to get a side effect, serious side effects. Then you select the availability. But the guidance usually, especially for chronic pain, if the patient tolerance, as Sannah said, some patients give them drug, but it doesn't work, give them side effects. So you always look for alternative. And as I said, we always measure the pain before and measure the pain after. Some drugs we give them like 2 to 3 weeks because they just work slowly, and then measure the patient's pain by themselves 2 weeks later. If we got 50%, that's the right dose. That's the right dose. If not, we have to change or sometimes use another drug to have a synergistic effect, so you can reduce the dosage of both drugs and become safer and improve the tolerance, which is side effects. Generally, the commonest cause for patient not taking the drug. Sometimes they feel worse with the side effects than the pain itself. They say, I've got the pain for a long time, I know how to cope with it. And then if they had a bad reaction to one of the drugs, it totally changed their life. So I really respect that. And that's why a simple rule is start small and go slow. So we titrate the dose to an effect. And we do that. To come back on the point which I think Sannah commented, and the addiction, people still, afraid of using especially opioid for addiction, and that's true. But again, that should not stop them from taking the medicine. If you really got pain, you will not get any high from taking any painkiller. So some patients are really afraid of taking simple analgesia for fear of addiction. So that's not founded fear, and we just advise them. And then the addiction is slightly different from tolerance. Tolerance, that means you give the patient the same drug, the same dose, and then the response starts to get less. You give him 1 tablet, you have a response. Give him 2 tablets, you're having the same response. So you need to give a bigger dose to get the same effect. So once that happened, it could be like a warning. You cannot just like a bucket keep pouring drugs on the patient. That's not safe. Then you have to stop and assess. Even addiction is like any other things. It's a disease. It has to be properly diagnosed and properly managed. And there is a very specific team, like proper multidisciplinary, because addiction is physical and psychological. You can't leave the patient only physically. You have to support him psychologically as well. And at the same time, find alternative to help their pain, because the patient is really panicky. If they stop whatever, that they will feel the pain again, which affect their quality of life. But one of the most important questions we go through when we get a patient like this, when the patient measure their pain and take a huge dose, say, for example, of morphine, but they still have severe pain. So the first step is to let them accept that the pain, the big dose of whatever they take, morphine or any other drug, is not helping their pain. So the justification why you take it is harming to you now, is reducing the chance of giving you more drugs because you get more side effects. So once you accept that you take big drugs not helping your pain, so that's the beginning of really accepting a proper either gradual reduction program or referral to a special center to help him coping with that addiction. I hope that cover the neuropathic and the addiction bit of it.
Yes, no, you've covered both angles. Thank you. But I guess focusing on disorders, I wanted your perspective, Dr. Aglan, about fibromyalgia. So this is a common widespread pain condition, isn't it? So
I found this on the web for, is there reducing the chance of giving you more drugs because you get more
Okay.
Sorry, I think Alexa already picked up your question and started to give me information about fibromyalgia. Fibromyalgia, to be honest, it's at the moment, it is a syndrome. And we call it syndrome because it's not like a disease. If you got less hemoglobin in your blood, we call that anemia, certain level. If you got depression of certain, like drawing in the ECG, then you know you got ischemia. But in fibromyalgia, you just get pain. And the pain is typically bilaterally and up and lower part of the body. So the classification of it is actually follow the American College of Rheumatology. So they looked at classical 18 points. If the patient generally during the examination have 11 or more, then clinically we say the patient's got fibromyalgia. But unfortunately, there's no specific or sensitive blood test or X-ray, which when we do diagnose it. So it's a clinical presentation, and that's part of the difficulty. So I tend to kill it. Usually if the patient come like this, maybe today he's got fibromyalgia, tomorrow or when the weather improve, she doesn't have fibromyalgia and she have a holiday on the beach, she doesn't have fibromyalgia. Once he come back to England with the cold weather, the fibromyalgia gets worse, which is true. The effect is obvious, but you need reassessment, number one. Number two is always frustrating because although we do not have a cure, but there is a lot of intervention. In the chronic pain clinic, we consider it like part of the neuropathic pain condition, and we follow the algorithm. But one of the commonest things as well need proper assessment, because patients sometimes come to us with widespread body pains. You cannot just label him fibromyalgia without proper assessment, number one. Number two, it's not uncommon that the patient may have fibromyalgia, but the fibromyalgia, don't forget, it's a muscle condition. So if the patient got like a disc, that's not a muscle condition. If the patient got like a special pressure, peripheral pressure on the nerve or neuropathy, that's not fibromyalgia. If the patient got severe stress at the back pain over the sacroiliac joint, which is one of the commonest weight-bearing joint, or a knee pain from the joint itself, joint pain is not fibromyalgia. So careful diagnosis and careful examination to find other cause of the patient pain. Sometimes we may not cure fibromyalgia. the patient still can cope with that mild fibromyalgia, but we can find other causes which we can really treat, and on the whole, reduce the patient pain experience and improve his quality of life. So back again, just put him back to function. But it's a real problem. And I think in every part of the country, there's a self-help group. So the patient you have to feel that he's not alone. There's a lot of other people. A few patients, we find that they may have some sort of allergy to certain drugs or some of the drinks or certain additive to certain food. And when they stopped it, the symptoms has improved. So again, careful history and assessment can help a lot of this patient. But new things, yes, we really, like in the pain clinic, there is, apart from the medication, if it doesn't work, we use something called lignocaine, which is a local anesthetic. We infuse that certain dose inside the patient's vein under ECG monitoring for safety. And that, at least in our hands, seems to be effective in reducing the patient's symptom for some time, which could be repeated later if needed. So we do that when the attack is really bad and the patient cannot tolerate any of the oral medications. So there's lots of intervention like in other conditions. There's lots of new, again, avenues which you can help with chronic pain patient, either fibromyalgia or any widespread patients. Sometimes the diagnosis is not clear. Like you do X-rays, it comes normal. MRI scan, nothing significant. You do bloods, is normal. So that seems frustrated, and the patient start to worry. Am I crazy? And some patient has been even giving the wrong advice that's in your mind, which it's not. I know pain generally is we feel it in the brain, but practically it's our job to find the cause, or in chronic pain, the causes. Usually there's multiple causes, both physical and psychological, which could be primary or secondary part of the pain, and then help the patient to cope, either fibromyalgia or any other widespread pain condition.
Sannah, in terms of acute pain, there's different ways that pain relief can be administered. So we've got oral, subcutaneous, transdermal, sublingual, rectal, so many ways you can get pain relief. In the acute setting with different kinds of acute injuries or actual pain, how would you select what type of pain relief should be given?
I think, well, what we do usually is we have a few assessments on urgency. How quickly do we want the pain to be gotten rid of? And scales are really important. We're always using pain scales. I know Dr. Aglan said 10. That sounds like a better number, but where we work, we have 1 to 4, which is, I think, a bit restrictive. But and we want to know what the patient's sort of medical background is. So, as you said, Fahim, in the acute setting, there's loads of different settings in the hospital where we use different kinds of pain relief. They're not all available in every single setting. So something that might be available in like operating theatre or in recovery might not be on a ward, might not be in the outpatients department, which is quite interesting. So usually post-op, you see things like subcutaneous or intramuscular or even IV through a drip is what the public usually call it, like intravenous, like quite potent morphine, oxycodone. There's also something that I learned about recently, like PCASs. It's just like a little box, and it's patient controlled. So whenever the patient needs pain relief, and it's really quick, really efficient, really effective. It's got stuff like oxycodone, morphine in it, and it's usually for patients. We use it a lot for spinals and gynae surgeries, which are quite messy because they end up being really painful. They are brilliant devices. You do need a bit of extra training on them and stuff, but they are fantastic. And for the more novel and unexpected kind of routes of administration, we use a lot of like rectal diazepam, rectal diclofenac, like Voltarol for people who know that from the gel. That seems to work quite well because it has less of a gastrointestinal effect, so it upsets the stomach a lot less, we've found. So in the more older patients in their late 60s who tend to stay away from oral naproxen because it's really caused them distress, because the stomach pains and the distress that you get from anti-inflammatories, as Dr. Aglan said, you'd rather have the pain that you started with than have the side effect of the drug that you're taking orally. But yeah, rectal, the thing with that route of administration, you have to treat the patient with a lot of dignity, and you have to also explain to them that it's got a huge, very strong evidence base. It works quickly, and they probably won't need another painkiller for overnight. So the benefits usually do outweigh the risks and the poor stigmas. And after they've had the first one, they're absolutely fine. Usually, it's just how you deal with them. I've not seen much in way of inhaled pain relief, but yeah, the Versatis plasters, people in the community seem to really love them. I think a few years ago when I was training, actually, they went completely out of stock and they completely got decommissioned. Nobody could get them. It caused a huge panic in the community because there was a lot of chronic pain in the community, and it shows how much of a burden the of pain actually presents to the community and workplaces and lifestyles. But they certainly do work. People have actually come back to the pharmacy and told me this is the first time I've used it, because I don't think it's something like first line or anything. Use it after trying a few things. So that's another one. That's the transdermal sort of route. We have similar to that, we have stuff like buprenorphine patches, fentanyl patches. They're used more for sort of end of life care, so the people who are sort of towards the end of their lives, or patients with like malignancy or something. The pain associated with those is quite horrible. Some patients who have sort of prolonged, really severe neuropathic pain, I've seen a lot of people, more people than you'd expect actually, on a sort of a low dose of an opioid pain relief patch. They're quite important for people like us who deal with surgeries, because obviously they can interact with a bunch of opioids and the anesthetics that we use and stuff. So we all have to be aware that the patient might not respond to the normal doses of pain relief that we give them, because we don't stop them either. And apart from that, just the normal sort of syringe drivers that we usually use for, we don't see syringe drivers that much, unfortunately, because I'm not on elderly wards anymore, but on an elderly ward you'd see, because it's very much associated with palliative care. They are quite specialist, but they're widely used because the patient has the control. And I think in hospital, especially in the acute setting, people go from having complete control over their lives to being in a state, being a patient is really difficult. So being in a state where they feel like everyone's taking care of them, they have no sort of say over what they're doing. So having like a morphine PC or having syringe driver, I think it really ups their confidence and their sort of sense of self-worth, really, and they feel a lot more in control of their pain relief. So they're a lot more involved in the story. But yeah.
Thanks. Dr. Aglan, I want to come to something interesting that I read a few months ago when we were planning this actual evening with you. And it's to do with chronic pain. There was an article in the BBC News which got a lot of coverage at the time. And it said that antidepressants are not actually painkillers, are recommended for chronic pain. And so many doctors were being advised, due to the NICE guidelines, that there was little evidence that common painkillers, including paracetamol and ibuprofen, for patients with chronic pain not caused by an injury or other medical conditions should get it. And instead they were recommending maybe acupuncture, psychological therapy, antidepressants instead. I was just wondering if you knew much about this and if you had anything to offer regarding this viewpoint.
I think it's a very good point, and it did trigger a lot of dispute and discussion. I could tell you exactly my experience. So when antidepressant has been used in pain medicine for a long time, chronic pain will definitely cause psychological effects. If you have pain every day in your life for 3 months, affecting your sleep, affecting your activity, affecting your relationship, unless you are a computer, if you're human, you will get some sort of effect, usually frustration, depression, plus on chronic other things or not. So the pain can initiate psychological aspect, and also psychological condition can cause pain. So they are interrelated. So when the patient presents you with that, either the psychological is primary or secondary, you need to treat that. You cannot ignore it. So there is too many actually different clinics use different things, but basically they are questionnaire. The patient measure the patient their own response and coping strategy, whatever. Once you find a high score, that means there's alarm. We call them red, not red, yellow flag signs. Then you have to start antidepressants. So in that case, you tell them not as a painkiller. Of course, that's wrong. You know, if you got an acute pain, you don't use specifically antidepressant for that. Use a proper painkiller. So that's it. So once you diagnose, you can treat. It's not separate. But to say that I cannot definitely separate psychological aspect from physical pain. In most of in all my patients I see, the majority of them do have psychological effects to a variable degree and have a poor sleep. And if you do not improve this condition, the patient will never get better, and you'll not get him from A to B, which is from bad to better, from unable to cope with daily activity to be able to cope, and that's the idea. So I won't ignore it, but in fact it is important, and there is, and as I said, medication, like any intervention, has to be measured. So if the patient take any intervention, including, like, for example, amitriptyline to help their sleep, and we give it at night. Why? Because it got like a drowsiness. So the patient feel drowsiness, it end up with his sleep. So he wake up again comfortable, at least with good sleep. But if you wake up really drowsy in the morning, the dose could be too much or not indicated, or you use something else. So once you give a drug and you measure the effect of it, then you are safe. But you can't say don't use that. I don't think that is practical, especially if when you assist a patient and you find enough evidence of both physical and psychological. And from the beginning, I try to explain that in chronic pain, we always look in the three spheres of pain: the biology of what's wrong, and the psychology, and the social effect. And if you miss any of these angle, you may not be giving the patient the best chance for improvement. And some people say, like, you know, I had a patient this afternoon, or actually, which he said, Dr. Aglan, yeah, the treatment did help me a lot, and I'm a lot better, but I'm not 100%. Then I said, in chronic pain, there's no 100%. So it depends. Like, if you ask the patient to measure their pain, no one will measure zero. You get zero only when you're asleep or dead. At the moment, like, I had a full day, I didn't have food, I didn't have enough water, so I feel headache. And if you ask me now, it's about 3 out of 10. But 3 out of 10 is bearable pain. All of us can cope with that for some time. But if I stay for 2-3 days, then it's a different condition. So it depends what you feel now. If you can cope with your pain, that's manageable. But if we're looking for zero pain, it is not like this, unless it's like a very specific acute condition. Then you treat the cause, infection, you treat specific antibiotic, kill the bacteria, then the pain goes away. But in chronic pain, it's a different type of pain, and most of the cases will help the patient cope. But coping means that he is being agony. That's wrong. It would have to be bearable pain, which everyone, if you ask you now, I'm sure you have all of us have got like a bit of knee, a bit of neck, whatever. If you really think about it, you will find some sort of discomfort. And we said from the beginning that pain is unpleasant. Who does not have unpleasantness in any day nowadays? You get out of, in the morning, out of home, there's something bothering you, and the same as well at night. So I think antidepressant is important part of our intervention and treatment, especially if the patient shows any psychological effects, and it has to be really attended and treated and monitored as well, like any other condition.
Great, thank you, Dr. Aglan. And I guess perhaps something to learn is from Sannah's rating scale from 0 to 4. That seems to at least achieve 0 pain outcomes. But you know, I just have to be mindful. The hour is nearly coming up, so
can you believe that?
I know, tell me about it. So I think it's that time where I'm going to ask for some 3 tips. So Sannah, if you can share some 3 tips that you can give to the public in terms of understanding and managing their pain, what would they be?
First of all, if it bothers you, and by I mean bothers you, it's affecting your life, acutely or chronically, however long it's been. If you haven't discussed it with a professional, do it now. Your GP, your pharmacist, anybody, Dr. Aglan, anyone, discuss it. That's my first tip. Do talk about it, because you never know how much help you can actually get. My second tip, try not to dismiss the over-the-counter remedies. Something like paracetamol, I think it's the most underrated drug in the whole world, because we prescribe it, we supply it, and it has an actually fantastic effect. And people try to start with cocodamol, people try to start with like huge doses of something that's prescription only, and because they just don't have enough faith in the paracetamol. But trust your pharmacist, trust your GP. If they're telling you to, if they're advising you rather, to get something over the counter, isn't that so much easier? Prescription charges are ridiculous at the moment. So the cheaper, the better, and the less sort of burden, financial, social, time. It just takes so long getting something prescribed regularly. So yeah, don't undervalue and don't dismiss the blessings of the over-the-counter pain relief. And third, monitor your pain. I think that's really important. Just because you're taking something, it doesn't have to work first time. Don't lose faith, but keep monitoring it. People who have community pharmacists probably hate us for saying this, but it works like magic. Keep a pain diary. Keeping a diary for a week or two, it helps you identify triggers so well that when you go to see a pain specialist, when you go to see a pharmacist, when you go to see a GP, it means that you've got something to work with. You're not just saying, oh, I've got a headache, and you have no idea how it works. And it helps you identify patterns in your life. So yeah, that's the third one.
Fantastic. Thank you, Sannah. And Dr. Aglan, if I ask you for your 3 tips, I'm going to give you 30 seconds if you can.
Fine, I'll try to finish time. I usually tell the patient what I call them like 10 commandments, but I'll try to summarize them in 3 points for you. In chronic pain, I think the most important bit, have a good sleep, because without good sleep, any pain can get worse. So that's whatever you do, we all deserve good sleep, either you have pain or not. Number 2, hydration. I think a lot of my chronic pain patients do have a problem with not drinking enough water. So hydration can help a lot of chronic pain condition. And then as Sannah said about monitoring, it's essential as well in chronic pain. But if I put another different point, is chronic pain need proper assessment, proper multidisciplinary assessment, because there's always hope, and there is tremendous new interventions, which we can talk about in another talk, in every type of pain, which made a big difference in the patient quality of life. So there's always hope. Don't just accept it. For me, there's no excuse for pain. You just have to proper assess and find a proper management plan to help the pain and his quality of life.
Fantastic. Thank you so much. And I guess I just want to thank you from behalf of Fahim and I just for sharing your hour on a Tuesday evening. It's been a fascinating discussion. We nearly went into philosophy towards the end, but we'll certainly do that perhaps after the show. But you know, again, thank you so much. And Fahim, if you'd just like to introduce our guest for next week.
Yeah, next week we have Dr. Soumya Jha, who's a GP based in London, and also Dr. Sannah Iqbal, who's another GP based in the Manchester area. So we're hoping to have a sort of a women's hour and issues of that nature next Tuesday, same time, 8 o'clock. Please do join us. Again, my big thanks both to Sannah and Dr. Aglan. I've learned a lot, and I'm sure the listeners and viewers have had a really inspirational 1 hour with you. So thank you again. That was really lovely. Thank you.
Thank you.
Thank you, guys.
Take care.